My name is Sophia Silao, and I am Program Officer at the NYHealth Foundation. Welcome to today's webinar. Our topic is about New York State's response to the opioid overdose crisis and ways to protect the state's investment in proven methods to reduce drug-related deaths. This session will be recorded and closed captioning is provided. We invite you to drop your name and your organization in the chat so we know who has joined us today. New York has been at the forefront of adopting pioneering public health strategies, including several harm reduction approaches. In the past few years, the state has funneled much-needed resources to support prevention, treatment, and recovery of individuals with substance use disorders and other addictions. Investment in these evidence-based strategies have paid off, and opioid-related deaths are trending in the right direction. Still, an estimated 4,500 New Yorkers lost their lives to preventable drug overdose last year, and these figures remain unacceptably high. Much has been in the news in recent months about the impact of federal funding cuts on state and local budgets, and the downstream effects of these cuts pose a threat to the progress in reducing unnecessary deaths. As summer winds down and state and local municipality leaders return to budget planning season, the changed funding landscape will be top of mind, and planning the use of the settlement fund dollars notwithstanding. We're joined by two leading community advocates who have dedicated their lives to enhancing comprehensive, person-centered support systems for people who use drugs. They will present the latest information about New York's opioid settlement funds and shed light on strategies to address gaps in the next phase of the work. Our first speaker is Tony Smith. Tony is the New York State Director at Drug Policy Alliance, a current grantee of NYHealth Foundation. At DPA, Tony does extensive work with community groups to improve systems of support for people who use drugs. She has years of experience working on grassroots organizing campaigns at the New York City Civil Liberties Union, where she focused on protecting public education and promoting racial justice. Tony is a mover and a shaker and was recognized by City and State New York on their powerful 100 education list in 2021 and in 2022. Our second speaker is Tracy M. Gardner. Tracy is a respected public health advocate and the executive director at the National Black Harm Reduction Network, where she works to address substance use and the disproportionate impact of the war on drugs on Black communities. Tracy's professional accomplishments are quite extensive and include serving as Senior Vice President of Policy Advocacy at the Legal Action Center and as New York State Assistant Secretary of Mental Hygiene in the Office of the Governor. Tracy is currently a member of the New York State Opioid Settlement Fund Advisory Board. Welcome. Welcome, Tracy. Welcome, Tony. Thanks for being here.
Thank you, Sophia.
Having us.
Look, Tracy, I'd like to start with you. Can you please help set the stage for us by providing some historical context of New York's response to drug-related deaths, harm reduction movement, and how government and community works together to guide investment in these issues?
Sure. And again, thank you so much for this invitation. I have been a grantee of the New York State Health Foundation, was certainly around when the conversion happened. And so some of the really important work that's happened in New York that I've been involved in has been driven by investments by the New York State Health Foundation. So this is a real honor. And it's always strange to give historical because I still feel like I am the public policy intern. But that time actually started in 1989 when I was working with funders concerned about AIDS. So that was a cohort of philanthropy that was focused on the HIV epidemic in the early 90s, late 80s. And then I was also working with a community-based organization called Minority Task Force on AIDS, based in Harlem, right in the middle of the epicenter. And so there's very much, for me, an arc of the work, of the issues, of the health emergency, and who's impacted. So what, kind of what did I see when I was working in HIV and AIDS? And I see a lot of friends on the call who were also involved that in New York in terms of what was going on prior to the protease inhibitor. So from 1990 until 1996, there was lots of death. There was lots of reaction, both good and bad. There was a lot of media attention. It's very much like the overdose epidemic that is happening now, and especially as it peaked right before COVID and then right after. And it really feels like New York in particular, we've had to learn a lot of lessons from how we respond to health emergencies, right? But we also have an historic infrastructure for all kinds of things, including health and also substance use disorder. The infrastructure for substance use disorder, however, has gone through different changes over the decades, built around whatever was the, kind of forward-thinking issue about what people needed, So, we had opioid or, farms for people uh, addicted to opioids back in the 40s and 50s. And I always tell people, this is not our first opioid epidemic. We had one in the 70s and we've had one even before. And so understanding that the infrastructure that we're now dealing with to deal with this particular health emergency has changed very little, except for the innovations that have been driven by the health emergencies, if that makes sense. So for me, I got to witness the emergence of the New York State Department of Health AIDS Institute, and, both understanding the politics and the role at the time. This was the health emergency that was happening on Governor Mario Cuomo's watch. He empowered his then health commissioner, Dr. David Axelrod, to address this in a way that you think best. And what Dr. Axelrod was able to marshal was a kind of center of excellence approach to HIV and AIDS. And again, this is 1990. This is before we knew so much, right? And people were getting their AIDS diagnosis and dying often as soon as they got the diagnosis, and certainly before they were getting support services to help them survive. There was no medical intervention except for AZT and DDI and all of these other medications with horrible side effects. And then, of course, the race equity issue there is the same as it is here. And if you map, even from the heroin epidemic, and then crack, and then HIV, and then COVID, you will see that the same neighborhoods and the same communities around the state are hit harder than in other parts of the state. And so we know, and I certainly learned working in HIV, that these communities were deeply affected by the federal war on drugs and New York State's implementation of it. New York State developed the mother of mandatory minimums in terms of the Rockefeller drug laws, and the incarceration, the mass incarceration of people who had little to very small amounts of drugs on their person ended up disrupting these very same communities by pulling out adults, disrupting sexual and other social networks, and all in the name of a governor who at the time, Nelson Rockefeller, was running for president, because tough on crime is the goal. So again, kind of, I can spin my history, at least in the involvement of HIV and seeing the rapid innovation that happened to respond to this emergency. Harm reduction emerged out of government neglect of people who use drugs and the devaluation of them, their lives, and their communities. And we need to keep that in mind, because what's happening in harm reduction now, or what harm reduction now is, I call it Harm Reduction Inc. In the same way that we got AIDS Inc. once the protease inhibitors were found to be effective, it then took the place of a clinical role rather than peer support and outreach. But harm reduction was developed by and for drug users who were trying to protect each other from transmission of HIV and other bloodborne diseases. When there was so much stigma and enmity toward drug users. And people, quite frankly, had the feeling that drug users should simply just die. And it's like a natural selection, if you will. And I've heard that sentiment directly for as long as I've been in this work, again, since 1989. So one of the things about the settlement board, and many people know, the state addiction agency worked very closely with the criminal legal system and with the mental hygiene system because, one, the way it's constructed under the statute in New York State, right? We have a health department and we have a mental hygiene department in statute that's made up of developmental disabilities, mental health, and addiction. So that was my stint in the governor's office, overseeing, being the governor's point on those three agencies. And boy, did I learn a lot being able to look under the hood of how those organizations, how those agencies were part of the state landscape of providing services, right? The mental hygiene sector, and not just in New York, but in every state, has generally been a dumping ground. It's been a place where the health issues of the mind are not addressed in the same way that we address health issues of the body. And that has been very much to our detriment even today. And so really this was about how do we get resources where we can address the epidemic and the drivers in ways that will be immediately effective. And you know what? I am not even aware of time, so just wave me down. But I guess the main thing that I wanted to talk about in setting up what Tony's going to be talking about in terms of the report by DPA and the role of the Opioid Settlement Fund Advisory Board and the role of opioid settlement dollars. We know what happened to tobacco settlement dollars. Okay, thank you. We know what happened to tobacco settlement dollars. And we have the good fortune to have our amazing AG, Tish James, lead the charge of other AGs to go after manufacturers who were actually totally negligent, both in terms of what they were telling patients and providers, and then the proliferation without acknowledging the dangerous elements of these medications. But it was the need for the treatment and the response that where we really saw the loss of life. And so whether government, in my experience, cannot do this alone. And that is what we are taking on. Advisory boards made up of people with lived experience, people who are closest to the problem, being united in partnership with government is how the money, the resources get to where they're needed the most. And quite frankly, that's not what's happening with the settlement board right now. But I think that there is hope, and reports like the one that DPA and Tony are driving really speak to we need to drive our resource recommendations by the data, informed by the expertise of the people who are working at where the problem is the worst, and integrate the living and lived experience of people who are directly impacted. That's what worked for HIV. And I never thought I would be alive to see HIV being addressed like a pill, but here we are. And that's the innovation, because people living with HIV and AIDS were involved in every aspect of the work. It can't be, it can't be not arbitrary, but it can't be optional. It has to be. Money should not even flow unless there is a concurrence and a partnership between government and community that ensures the money will go to where it's needed. So I'm gonna stop talking now because I really want to get into what DPA has been able to do and what an asset it's been to the board's work and the board's work to come.
Thank you, Tracy. And it's really interesting to hear, this consistent through line that you spoke of in the state's response to this issue. And so, you did allude to this that as part of the lawsuit led by New York State Attorney General Letitia James, that New York receives opioid settlement dollars to help pay for local and state initiatives to address this opioid crisis. And the funds really started to flow to the community in around 2022. So I wanted to ask Tony, DPA just recently completed an analysis of the use of the funds so far, and would love to hear what your team has uncovered.
Thanks so much, Sophia. And thank you also. New York Health Foundation has been a really strong and amazing partner, and I'm really, really happy for the opportunity to share this information with you and a lot of the familiar and unfamiliar names that I see in the chat. Hi, everyone. And I also see some brilliant data scientists on here, so I hope this report is valuable to you all. So yeah, New York's opioid settlement funds, the total across all years that are expected to be paid to New York State, top $3 billion. And the money has started to roll out in the last couple of years. And we've been following these funds very closely. As background, DPA works with community-based groups to identify and respond holistically to needs related to substance use and people who use substances. And in collaboration with these groups and in other movements, we work to change laws, advance justice, and save lives. And so about a year and a half ago, we began regularly attending meetings of Friends of Echo Park, which is a community group in East Tremont who were concerned about overdoses and other harms related to substance use that they were seeing in their neighborhood. They had heard about opioid settlement funds, and since the Bronx has some of the highest rates of overdose deaths in the state, they began asking whether their community was getting any of these funds. And the Drug Policy Alliance, as we've been closely monitoring the opioid settlement fund implementation since the initial settlements were reached, even we found it was difficult to give community members the clear answers about where the money was going and who it was helping that they were seeking. And so at the time, at the same time, we were in regular attendance at Opioid Settlement Board meetings, and following the conversations happening there, board members were asking for better data to help them make effective spending recommendations. And so we set out to answer the most common questions we were hearing, with the goal that by doing an early analysis of these funds, it would support funding decisions for the remaining 15 or so years of funding. Now, I will say we know that the state is in the process of doing an official evaluation of the funds to date. And we wanted to provide something sooner, even if it was less formal. And I also want to make clear there's really great work happening across the state by really dedicated people. And there are gaps that collectively we want to close. And so this report is in that spirit. So this report, we're going to show some slides to give a preview of the report. The report gives a background on opioid settlement funds. It looks at the current state of the overdose crisis for context. It details the first 3 years of spending and pulls key themes from public testimony at the Opioid Settlement Board meetings between 2022 and 2024. So thank you. And so thank you so much. So in the year that we've been working on this report, the state has announced a 34% reduction in overdose deaths between 2023 and 2024. But the 2024 data does not yet include a detailed breakdown of the approximately 4,500 New Yorkers who still died of an overdose last year. We know from previous years' data that communities of color are experiencing this crisis more severely, and so it's important to look at trends in deaths across demographics. And so here is a snapshot of overdose deaths across the state in 2023. This data is pulled from the New York Office of Addiction Services and Supports, and other data in the report is pulled from the CDC. Those are the two primary sources we're using for this report. Figure 1 here is a map of deaths by county. As you can see, the rates are different in different parts of the state. The darker the shade, the higher the rate of death. In the next slide, we will see that the crisis is also being felt differently along demographic lines. And it's important to track trends, not just snapshots in time. And so figure 2 here looks at rates of death by race and ethnicity. And you can see that Black and Indigenous people had the highest rates of overdose death. And as of now, we don't yet see the rates of death beginning to stabilize among Black New Yorkers as we do with the rest of the population. We will have to wait for official 2024 data with more granular breakdown in order to assess that. In the next slide, figure 3 looks at the impact of the crisis by age group. The highest rate of overdose death among age groups occurred in people 35 to 44 years old and 55 to 64 years old. And I want to add here, all of this data on just the state of the overdose crisis is publicly available data. We've included in the report so that it is easily available to see in the context of talking about and thinking about making funding recommendations. New York we have a lot of data. We have the Office of Addiction Services and Supports has data on their website. The New York State Department of Health has data on its website. Counties have their own data that they publish in different formats, and there's data on the CDC. The CDC publishes data as well, and they have a whole database. And so what we were hearing at board meetings wasn't just that there was not always the right kind of data, but there was not enough work being done to make meaning out of the data. And so often we see lots of different dashboards, and we can't tell what it's telling us about the state of the crisis and what we need to be doing about it. So on the next slide, we see a breakdown by gender, and we can see that male New Yorkers accounted for 72% of all deaths. Now, what these slides don't tell us is what overdose deaths look like when you look at multiple variables of data together. For example, race and age. New York City's 2023 report states that Black New Yorkers ages 55 to 84 had a rate of death that was double the statewide rate for the same age group across races. And so we don't see that when we're looking at just one variable at a time. And so two of the most persistent themes we heard at board meetings were high rates of death among Black New Yorkers and lack of access to services in rural counties. In thinking about how to use data to inform better funding decisions, we did an analysis by race and urban-rural setting. Again, we can see that looking at multiple variables at a time really changes how we understand who is bearing the brunt of the crisis. As rates leveled off for white people in both urban and rural areas, rates increased for Black people in urban settings and skyrocket for Black people in rural settings. Now the money. Next. A simple way to understand what is a very complicated funding structure is that there are two ways settlement monies are paid: directly to the state or directly to counties. This is important because the entity that gets the money is who is responsible for how the money is spent. According to the 2024 financial report published on the OASAS website, roughly half of the funds went to New York State, shown here in orange, and the other half went directly to counties. In the first 3 years, roughly $640 million was received in total. And then in the next slide, we can begin to look at how that money was awarded. Now here, so this slide shows the state's share, just the orange slice, the state's share of funding and how it was awarded during the first 3 years, broken out by category. This represents about $390 million and about 373 funding awards. So far, only a small portion of this total funds is publicly reported in detail. And that's part of what we wanted to do with this report, is to highlight where are the gaps in the transparency about where funding is going and the reporting mechanisms that are in place. And the reporting that is available so far is reported in a way that's hard to see a full picture of where the money is going and what kinds of services it's supporting. You know, you'll have to sort of click through on one page, you can get one set of information, and then you click to another page. And so it's really hard to see a full picture. And it was only effective this year that the legislature amended reporting requirements. So now the money that goes directly to counties will need to be reported publicly as well. That has not been the case and was not the case during the first 3 years. So in the next slide, we mapped the funding awards. One of the initial questions we got from community members was, where's the money going? And we know from attending board meetings, we know money is getting out the door. We know from working with providers that some people are receiving awards, but it was hard to paint a picture. So this map, which will be, when the report is published, this will be an online interactive map, plots 192 of the publicly reported funding awards that were reported on the OASAS website. So again, this only represents a slice of total opioid settlement funds. About $108 million is represented on this map out of, right, like $640 million that has been reportedly received across the state. And so each pin here represents an organization's address, which may differ from where services are provided. The pin sizes indicate funding amounts starting at $9,500 and going into the millions. And the color of the pins represent the category of funding. In total, 41 counties received state awarded funds. Then we wanted to know kind of what was the breakdown of funds by recipient. And so in the next slide, we looked at how the funding broke out between larger scale organizations and community-based organizations. Sorry, I'll get to the next slide here. Okay. And so we saw the majority of the funds, the majority of the state funds went to large scale institutions or organizations. And again, right, there's information that we don't have as part of this analysis, including how counties are spending their funds. And we know that counties are more likely to be supporting local efforts and smaller organizations. So again, this is just a slice of how funding was distributed and doesn't represent the totality of how funding distributions are looking across all funds, but it is one slice. Thank you so much. Now remember, roughly half of all opioid settlement funds go directly to counties. These funds have not been reported in a full or consistent way so far, and there was not a requirement to do that. So, but we wanted to provide some information on these funds. We don't want it to be a complete mystery for people asking questions. So we searched online for information about how counties have spent their money so far. And we searched the way an average person who's interested in a topic may search. Run a Google search, search a couple of pages, and see what is available. And so this figure is a simplified summary of what we found. For 35% of counties, we didn't find any information about how they've used their funds. But this provides a rough view of the kinds of services that are being funded through county level spending. And the published report includes a more detailed chart of awards by county. Finally, we did an analysis of public testimony. And so in the next slide, we can see key themes we pulled from the testimony, from the public testimony. 1, that funding favors large institutions. 2, stigmatizing and punitive treatment prevents people from receiving health services. 3, workforce burnout and turnover is high. 4, state data does not include long-term outcomes. And 5, board meetings are not accessible enough. And I want to read just a couple of quotes pulled from the public testimony in the next few slides. I was failed by 2 different treatment centers and the state system before I got sober. And in 2018, I overdosed. I was actually declared legally dead. I was completely alone during my overdose. The nurses and doctors in the hospital were shaking their heads, full of disgust and pity. The only person who talked to me that night was a police officer who wanted to know where the drugs came from. I have 3 sons, and 2 of them struggle with substance use disorder. My oldest son is 4.5 years into his recovery, and my other son is currently incarcerated in our county jail, serving a 2-year sentence. Folks in our county face many barriers when attempting to access treatment. Transportation is one of those barriers. The closest methadone clinic is a minimum of an hour one way, and the same for inpatient treatment. In 2016, I was the last person requested to speak at the Heroin Task Force, and I implored people to make sure that as we keep things broad, we remember that when we're not specific and we're not targeted, Black people will continue to bear the brunt. As you saw in the data, we are dying. That was in 2022. A little later in the conversation, we will come back to these recommendations. Right now, I will turn it back over to you, Sophia.
Thank you, Tony. And those testimonies are so powerful and really bring it all that data home to bear, right? So at the New York Health Foundation, our work is firmly rooted in the idea that all New Yorkers are entitled to health services and the care that they need. At this particular moment, it's critical that we amplify the message about the importance of investing in public health and in mitigating barriers to care. But the reality is that access to healthcare is not the same for everyone, as those testimonies sort of help to underscore. And for many individuals, you can get punished or even harmed for seeking out these services. I'd love to hear from either of you, if you could speak a little bit more about this.
Well, again, this is not the first rodeo for New York in terms of a health emergency that happened where a system that didn't have enough infrastructure to address it, right? And so I talked earlier a lot about the Department of Health AIDS Institute and the more than 40 years of developing infrastructure to respond to the HIV epidemic as it was happening among the hardest hit. Gay men, sexually active folks, sexual and gender minorities, and I put that in quotes, and injection drug users. And there was so much political around the issues and the people, right? And again, I told you earlier, I was the old cranky lady, but the connection between the history of less than 40 years ago and now is absolutely critical because we know what we did worked, or we wouldn't. I'm not saying HIV is perfect where we are. Black people continue to comprise the new HIV infections all over this country, but there is infrastructure that has been built around what we know that can happen clinically with HIV, and then what people need in order to benefit from these clinical interventions like housing or access to quote unquote behavioral health, a term I hate. It's really holistic, mental health, substance use. There are two different systems that have been constructed to deal with these two issues that affect the brain. But I would be remiss in leaving here and not talking about the success of community planning and how, at least personally, I know many on the call have experienced the benefits of creating the opportunities, the venues, and the input that comes in. This is not just, checking off a box community planning. This is CDC HIV prevention planning dollars. This is federal HRSA Ryan White care dollars that had built into the language that the jurisdictions don't get the money unless they can demonstrate an agreement, or in the case of CDC, concurrence about where the money should go to address the problem where it was the greatest. And it simply, to me, cannot happen any other way. If no other reason, this is not to malign anyone, but I got to see close up and personal that government cannot make the right decisions unless there is an engagement with community. The legislature cannot make the right decisions unless there is community input and engagement. And I put it on the laps of philanthropy to ensure that community can be part of community planning in health, because it leverages dollars that philanthropy shouldn't have to provide. Now, putting aside the catastrophe that we're in federally, there's lots of protections for settlement dollars that we want to insist upon. And as an advocate who's done grassroots lobbying, I never accept that there's not enough money, because I see what money has been used to spend on that is stupid. So I know there's money for smart things. So this is really about raising the awareness of settlement dollars that are easily some of the biggest infusion of dollars into the addiction field in lifetime. And that we've got an opportunity to reform, fix what was broken, although some people believe it was deliberately set up to hurt Black and Brown communities and to criminalize and stigmatize. But we see what that structure remaining unchanged has gotten us, right? There are lots of stakeholders in this, but at every single component, when you kill the voice or put barriers in the way of people who are living with the realities of the issue, from coming in to give guidance and recommendations about how money can be best sent, you're setting yourself up for failure. And we have also seen that. So I had a chance to be on both the prevention planning group in the city. There was one at the state. There was the HIV Planning Council for the Ryan White dollars. And there was also the New York State AIDS Advisory Council, which was advisory, but there were lots of opportunities to engage community in the direction that the state was going in to address HIV and AIDS. And we wouldn't have the Epidemic Initiative without the AIDS Advisory Council and without community input that said, given the medications, and I'm pointing to the medications in particular, we can bring down new infections to under epidemic rates. Given the medications and what we know about opioid use disorder, substance use disorder, polysubstance use, stimulant disorder, we can bring the number of overdoses down to below epidemic levels, and we can make sure to stop the trend that is currently happening of Black New Yorkers dying unnecessarily, preventable deaths from overdose. In New York City, overdose and suicide are the leading causes of Black maternal mortality. We're also seeing the older Black folks, Black and Latino folks, a whole generation of people who survived heroin, crack, AIDS, but now with fentanyl, they started disappearing. I know for a fact because I was in the governor's office in 2015. And so we can't also prioritize populations. We need to prioritize around where the data is telling us the problem is worse. And just to underscore what Tony said, different state agencies have different capacities to collect data. And I was raised on the data from the health department. I was raised that there are multiple elements to look at to create the picture of the health epidemic and its impact on the community. There can't be only a few factors that you're looking at. So that's what we need as a board. We need to know what's currently going on with the epidemic in the state. We need to know where it's hot, where it's burning, where it's unaddressed. And when we go into recommendations, we need to face the reality that many of the organizations closest to the problem are not going to be equipped for Grants Gateway and the other bureaucratic mechanisms to get funding, nor should we demand that they do so. We have to be more creative about how to get that money immediately with urgency to the people and the organizations that are closest to what is going on.
Tony, Tracy just teed up the next part of this discussion, which I really wanted to give you the space to share with us the key recommendations that DPA highlighted in the report in terms of how to effectively use this settlement dollars.
Sure, thank you. And I'll say, hopefully, through ongoing conversations and partnership between government and community, more recommendations will emerge. This is a place to not even start, right? But this is a place for today. And I want to say before I give the recommendations, to add to what Tracy was saying, just about the current moment, we know in general, and we see from the public testimony, that there's still lots of stigma and punishment of people who use drugs. And as we see increased efforts to force people out of public spaces and into settings that are not what they want and not appropriate and harmful, We need to remember that people are often not able to receive the care they want when they seek it. And so part of the opportunity with the settlement funds is to build the infrastructure that allows people to receive the kind of care that they want when they want it. When people don't, they are less stable, right? Less well. And often the consequences of that play out in public spaces where people are punished again. And that cannot be acceptable. And so the broad recommendations in the report are: one, we need to establish a measurable statewide plan to address the overdose crisis. I saw in the chat, thank you for sharing, a link to the state health department data. There's a ton of data. We've been pouring through the data. There's a ton of data on the health department website. There's a ton of data on the OASAS website, and we've even went into CDC Wonder. We need all of that data to be working together, and not just data on deaths, but data on other health indicators that impact why people are dying, right? What comorbidities are existing that are elevating risks of death for certain populations. And that data needs to not just be available, but usable. It would be really great if all of the opioid settlement funding awards were available in a downloadable spreadsheet where you could look at it that way, rather than going page by page trying to figure out where did this money go in my county. So that's one. We need a measurable statewide plan. Right now, there is no statewide plan that says, right now, the crisis is here. In 5 years, we want the crisis to be here. What do we need to do in the next 5 years to go from point A to point B? We don't have that, which is like mind-boggling. So that's one. Two, we need to invest in community-based services that focus on overall well-being. We are seeing across the country, cities and states moving away from services that are under the umbrella of harm reduction, right? It's important to remember that giving people what they need when they need it allows people to then make other choices and become more stable. And so the more people are stigmatized and pushed away from services, the harder it's going to be to address all of the ways that the crisis is unfolding in our communities. Thank you. We need to support community-based organizations to apply for funding. We recognize in the pie chart that showed that the majority of state awards went to large-scale institutions. We know that part of that is because it's really hard for small organizations to apply for funding. You have to be registered in the state system. You then need to have the capabilities and the capacity to go through a grant application process. You need to know that funding is available. You need to know where to look. There's a lot of steps to even get to, can I get this funding? And this is a conversation that has been happening at the board meetings. And it's a conversation that needs to continue. So we know that there are conversations happening, recognizing this is an issue, and we encourage that we really need to figure out how to make it work, as Tracy said. 4, expand programs that are designed to serve underserved communities, people in rural areas, communities of color. There has to be an intentional focus on understanding what specific communities need and organizing funding in a way that addresses the particular gaps in communities. It is not going to be effective to get funding where it is needed to enact broad policies and then hope investments are going to get where they're needed, right? We actually need to know what's happening, the particularities on the ground in different communities to make sure services reach.
Just insert the disproportionality is critical here. Because unless there's an intentional examination of, I think we can still say health disparities, but the disparities are where the problems persist. And if we don't recognize them and target them, then, again, I'm bringing up the collective New York memory of HIV and the kinds of things that we did going, under bridges and into the shelter system and, where people were to bring the service and make it intensive and engage and create relationships that then people trusted to be able to come into care. We know how this works. Sorry, Dawn, go ahead.
No, thank you. Next is to train and support community-based workers with lived experience. Of course, this is happening to an extent already, and we want to underscore that it's really important to make sure there aren't unnecessary barriers in the way of people getting into the workforce, people who are dedicated, who want employment in this field, but who really need pathways and support to not only enter the workforce, but be supported to stay in the workforce. And then regular reporting on the details and impact of funding. Again, there's a lot of information, a lot of data that gets shared. It's not always the right data to make the next set of decisions about where funding needs to go. So regular reporting on details of the funding and the impact will go a long way. Finally, actually not finally, I'm going to add one more, but allowing virtual testimony options at board meetings. Even though we analyzed 140 public comments, we recognize that this does not represent the entire state. There are many communities that never were at a board meeting who we haven't heard from because it is just not feasible to take a day off of work and go to. Now there are multiple meeting options, which I will give a lot of credit to the board and the state for pushing for that, right? Board members pushed for that. And so now there are multiple locations across the state where you can attend a board meeting in person. I think now it's New York City, Albany, Rochester, Buffalo. Are all of those, or did I make that up?
Albany, Rochester, Buffalo, correct.
Yeah.
And if people don't go to the meetings, then the case to be made that they're needed is hard to defend.
So yes, go to the meetings if you can, and people should be able to attend the meetings virtually and have their voice heard, not just watch the recording afterward. Finally, I'm adding this one, we have to make sure these funds are not used to fill budget gaps without completely exhausting other options. We recognize we are in a different landscape now, right? And funding decisions may have to look different in the future. And that is not a justification to, as a first resort, say we have this pot of money that we can use to be the stopgap for the substance use care infrastructure. That is not okay. These funds were hard fought to go above and beyond state investments to get us out of a crisis, not to continue the status quo of the crisis. And so that needs to be a priority on our elected leaders, by the governor, at the state and local levels, actually.
Can I add a recommendation?
Of course.
Since we are being hosted by a philanthropy, and I know I said it before, but it really cannot be underscored because I think there is, given the current environment since January, this idea of what can private philanthropy do, there is no expectation that private philanthropy can fill the gaps that have now been even expanded with the retreat in federal and then subsequently state dollars. But the funding, the work that leverages the ability of community to be creative, innovative, to build bridges, to develop mutual aid and support, to create more opportunities, to bring needs. You know, there's still a value in a town meeting. And again, many of us on the call grew up when ACT UP showed at a meeting, it was on and popping, right? Like the meetings, the discussion can get unruly, but this has always been about people's lives and feeling that they aren't being heard, and that in not being heard, they're being consigned to die. And so that is going to make anyone emotional. The reality is, though, we know what works. And so the recommendation about philanthropy, and that we start to think more expansively of what we mean by harm reduction, or what we know harm reduction also means. Harm reduction, prevention is the ultimate in harm reduction. There isn't a binary in terms of harm reduction and prevention, harm reduction and abstinence-based recovery, harm reduction and abstinence. We are about keeping people alive to make choices that are the best choices for them. And no more than you can force anyone into treatment and make them healthy, that you can insist that there be only one way. We have a healthcare and a addiction care system that was not, an addiction care system that didn't have a deep investment in people getting well, because it didn't believe they were sick in the first place. it believed they were willful, they were immoral, and so they were consigned to carceral approaches. And if, as we recognize that and see that, we need to root it out, and it needs to be replaced with what we know works. My final word is we cannot put new wine into old wineskins. And again, this is not beating up on New York. This is happening all over the country. Everywhere there's a Martin Luther King Jr. Boulevard, there are these convergent of issues that are having a disproportionate impact on Black and Brown communities. Black people and Indigenous and Native American communities are suffering mortality that is simply, I'm sorry, but it is because it's preventable, and they're the barriers that are keeping people from being alive are, I think, willful in some ways. So I'll get off my soapbox. And suitors. I see Anda Vecchio is mentioning that. So I've always been a data nerd, and working in HIV has taught me that, because there were always community planning, service delivery plans, y'all, on the HIV care networks. Always communities were being asked to assess what was going on in their communities and then communicate that to the federal government, to the state government. And so Suitors is a place that gives you a rich picture of what is going on across different elements and different platforms of data to create a picture that is multidimensional. However, the board, the settlement board, could not and should not have to generate data sets for us to be informed on our decision making, for us to inform our decision making. And you can self-generate to a certain extent, but it's, as Tony mentioned, there have been challenges in getting the data that we need in order to make informed recommendations.
Awesome. Thank you so much. And clearly this is a very thought-provoking conversation. We are seeing a lot of chatter on the chat box here, and thank you everyone for your comments. I wanted to just bring up one question that I think is top of mind for a lot of folks on this in the crowd here. Curious about when this DPA report will be made public, Tony. I think we have a lot of folks who want to get their hands on it and read it.
By the end of September.
Okay.
That's our goal.
You heard it here. All
Tracy,
right.
when is the next settlement board meeting is listed as September 12th?
That's right. And so that's another thing that the board has made some resolutions about, is that we are going to do much more and work closely with OASIS and with the health department to make the board's deliberations and utilize the technology so that people can really monitor and have insight about what this funding is being used for and what it can be used for. And especially to bring in folks who are doing the work directly with people who are not just people dying, but people who survive their overdoses, people who've been impacted, the prevention, the recovery centers are places where harm reduction can be discussed. There's just so much that could be done, but if the board can't have access to the collective wisdom and experience that's out there, then we can't effectively make recommendations. They are not, but they are good recommendations.
I want to slip in one last question before we have to round out this this talk here. Someone who's curious about the percentage of state settlement funds that went to treatment, and what are the parameters around what was counted as treatment?
So interesting. One of the things that we were working through in our analysis is the way that the state is currently reporting the funding awards is on the map that we provide in the report. The awards are listed out by a set of categories. Those are not one-to-one with the categories that are in the pie chart breakdown. So one of the difficulties we had, and one of the things I think for the board and the state to make more transparent and figure out, is exactly this question, right? When we see the pie chart of the different percentages of funding for each category, which funding awards were part of that? And where did those funds go? So it's a great question. We don't have an immediate answer, but that's one of the things we actually want to surface in the report as a gap that we want the state and the board to address.
Okay, so in terms of how we can stay engaged, there is talk about attending these open
Settlement board
advisory
meetings,
board
yeah.
meetings, right? Public comments. There
Get
was
your
some
voice
recommend.
heard, submit, and you can also, if you can't make it to a meeting, you can submit written public comments to the board at any time. There's an email on the OASAS website with their email that I don't know off the top of my head. You can email them any time. For DPA, we want to be in collaboration and community with more people. You can email us at nypo@drugpolicy.org.
Right.
I think my
And I did
colleagues
not,
on the webinar, if you want to put that email in the chat, please.
and I neglected, because we jumped right into this, to just mention that this is work that National Black Harm Reduction Network is doing in New York, happily in collaboration with Drug Policy Alliance and with other folks who are concerned about where settlement dollars will go with respect to housing, with respect to the child welfare family policing system, with respect to supporting the continuum of services, with respect to supporting the stuff that we know that works, like overdose prevention centers. So I can be reached at info@nbhrn.org.
And finally, Sunday is International Overdose Awareness Day. It is really important that conversations about these funds and the overdose crisis exist beyond defined drug policy, substance use oriented communities and networks, right? This is an issue that intersects with every walk of life. Consider marking the day in your own communities, in your own networks. Consider talking about this issue in spaces where substance use and related issues are not always talked about openly, where there's still a lot of stigma, a lot of shame, and a lot of fear around having these conversations. And we are both available for resources if you want to have those conversations and don't know how.
Thank you very much. And that's all the time we have left for today. We just got started on this conversation. But this was very, very helpful. Tony, Tracy, I want to thank you both for your time and for this very thought-provoking presentation.